Well, hello, everyone. It is noon on the East Coast, 9 a.m. on the West Coast, and you know what that means. That means we be jamming. Welcome to our Crisis Jam. As you see, we start with our map showing us our participation. We do have participation from all 50 states. The states in red, the 11 states in red, are the states that have Medicaid participation. We do encourage you to get your Medicaid offices participating in the Crisis Jam. And if your state is participating and you don't see yourself listed, please let us know that also. And we also have 64 national organizations that are participating in our Crisis Jam. Next slide. I want to remind you of our 988 Crisis Jam learning community. You have here of the different ways that you can access information. As a reminder, this website is at talk.crisisnow.com. Also want to remind you that the Crisis Jam will continue into the new fiscal year. I think a number of people have asked about whether or not the conversations were going to end, but the conversation will continue. And if you get the Crisis Talk newsletter, there is a link in there where you can click on the link, and it contains the link to continue participating in the Crisis Jam. And I believe Karen has also dropped it in the chat. Next slide. So here you see our recent Crisis Jam highlights, and you see the things that we will be doing today. We will have our trivia hot seat. We will be talking about some of the things that are coming up soon. We'll be talking about our upcoming presentations. And so all those things are things that you will want to make sure that you tune in for. Next slide. I also want to remind everyone about the state of reform, which will be one of our future presentations. You see here, Arizona behavioral health experts say 988 will create a more appropriate and patient-friendly response system. So we do encourage you to tune in as this will be one of our featured presentations. Next slide. And then also for our latest crisis news, we want to invite you to join us on Wednesday, July 6th, where we will have an in-depth overview of the playbooks for our new 988 implementation. Recognizing that the launch of the 988 number is fast approaching, and so we want you to stay informed. Next slide. 988 will be available nationwide on July 16th, and the best way for you to stay up to date with that is, one, make sure that you do check out our learning community, but we also encourage you to continue to be a part of these conversations where we continue to talk about what is to be expected, where we continue to share updates from the different states and different communities, and where we attempt to keep you informed about all the latest crisis news. Next slide. A reminder that our 988 Crisis 988 Goes Live Jam session on July 13th at noon will feature a presentation by Dr. Miriam Delphine Rittman, our Assistant Secretary for Mental Health and Substance Use, and that will be hosted by our very own David Covington, the President and CEO of RI International. Next slide. Here you see a quote from today's featured presenter, Matthew Goldman. Matthew is the medical director for comprehensive crisis services at the San Francisco Department of Public Health. And I'll let Matthew talk a little bit about this quote as a part of his presentation. Matthew, take it away.
Thank you so much, Vic, for that introduction. It looks like we might actually have a different quote up here than I think what we had expected, but this is still a useful and illustrative quote, which I'm happy to read. Sorry, I'm not familiar with this quote, but what it says here is where the city once counted people who are unemployed and experiencing mental health and substance use challenges As its primary homeless population, an increasing number of working San Franciscans and their families are joining the homeless shelter waiting lists and dining room lines. There are people with jobs, there are people who work full time and still can't afford to live in the city. This is an older quote from 2014, and I had suggested that we instead use a quote from a recipient of San Francisco's street crisis response team services. And fortunately, I have a couple other quotes that I'll be sharing with you from that group as well. So we can go to the next slide, and no worries about that. So again, I'm Matt Goldman. I'm the medical director for crisis services for the County of San Francisco Department of Public Health. I'm also on volunteer faculty at UCSF, and I'm going to be presenting today on crisis services for people experiencing homelessness. Usually I'm on the Crisis Jam talking about research in crisis services, and I facilitate the data corner that many folks have now gotten to see, but I'll be changing gears a little bit here rather than beating the drum of we need more research, and instead focusing on this really important issue of how to tailor crisis services for people who are experiencing homelessness. Next slide, please. So today I'm going to define PEH, or people experiencing homelessness. I'll describe how to tailor crisis services across the crisis continuum, and then wrap up with some takeaways. And I do want to give a shout out to Sam Jackson, Megan McDaniel, Siva Sundaram, Kathleen Silk Johnson, and many others who helped create and inform these slides. Always a team effort. Next slide. So I'll start with the definition of homeless. And first, I'll frame this as, why do we use the term person experiencing homelessness? You know, often people talk about homeless people, but for the same reason that the field has moved away from terms like, you know, describing a schizophrenic, or manic depressive, or somebody who even a diabetic. There's all kinds of those terms where you're defining the person by part of them, but not wanting to define a person wholly by certain of these attributes. Person experiencing homelessness identifies a person's personhood, and recognizes that homelessness is just an experience, but that somebody is not necessarily labeled or branded as a homeless person. And so, using that person-centered language, homeless is defined by the federal regulations. So this is from the Housing and Urban Development federal agency or federal department. And it's a broad definition. So this includes people who lack a fixed, regular, and adequate nighttime residence. And that could be in a variety of different settings. It includes people who are living in a supervised, publicly or privately operated shelter, or temporary living arrangement, including congregate shelter, transitional housing, hotels, and motels. It also includes people who would be considered runaway or unaccompanied youth, and then also people who are fleeing intimate partner and other violence. So I think understanding the breadth of what includes people who are experiencing homelessness is important to consider here. Next slide. Importantly, people who are experiencing homelessness have worse outcomes, and there are disparities as well. So in the United States, 2.5 to 3.5 million people cycle through homelessness each year in the United States. At any point in time, so in 2020, the last time pre-COVID that a point in time or pit count was completed, there were about 580,000 people who are experiencing homelessness in the United States. But as you can see, 2.5 to 3.5 million people cycling through homelessness. That means that although there might only be about 600,000 at any given time, there are many more who experience homelessness at some point in a given year. This map on the right here shows how this is distributed across the United States. And you can see, certainly California on the West Coast, and then also in Alaska, Hawaii, and New York, and Massachusetts are some of the leading states that have 50 or more people per 10,000 who are experiencing homelessness. There are disparities in this population. 34% are Black, 20% are Latinx, 4% are American Indian, Alaska Native, and those numbers all overrepresent those groups relative to the demographics of the population in the United States. 15% of arrests and incarceration are of people experiencing homelessness, so very overrepresented in that group. People who experience homelessness also have much higher rates of mental health and substance use disorder diagnoses compared to the general population. So clearly, this is a group that it needs to be a priority population for behavioral health systems and for crisis services in particular. Next slide, please. So crisis services have to be tailored to serve people experiencing homelessness. This is really the takeaway message, is that people experiencing homelessness also lack a home in our crisis systems. There are many important factors to consider here. There's a lot of stigma and bias at play when talking about people experiencing homelessness, and we have to be aware of that even internally within ourselves as we're doing this work. There's need for cross-training crisis responders with housing support staff and really integrating behavioral health and housing-related services wherever possible. There's great value in diverting people experiencing homelessness from law enforcement response, given that they are at such great risk of incarceration. And there's also a really important need to collect data on housing status in order to understand the presence of people experiencing homelessness in populations that are receiving behavioral health crisis type services. Next slide. And so I'll be speaking here from general experience, but also here in San Francisco, we do have a program that is very much doing this work. It's on the ground, it's doing the work, and I'm excited to get to talk about it here. So the Street Crisis Response Team in San Francisco is a 911 dispatched, neighborhood-based multidisciplinary team comprised of a behavioral health clinician, a community paramedic, and also a peer support specialist. This team provides direct crisis response, again, dispatched by 911, and there's also an accompanying team called Office of Coordinated Care that provides follow-up with short-term high-touch care linkage and follow-up services. This is a cross-agency collaboration between the Department of Public Health, San Francisco Fire Department, and also community-based organizations in San Francisco. And this is part of Mental Health San Francisco, which is a package of mental health programs for people experiencing homelessness that was funded by a tax initiative on high-earning businesses in San Francisco. This is a multi-stage launch for this program. It first initiated in November 2020, and we just initiated phase 2 of this program. And on to the next slide. Some sort of descriptive outcomes of this team and the services that are provided. So the Street Crisis Response Team handles about 700 calls a month at this point. They're responding to 60% of calls that are coded for this type of response. Those are when San Francisco received police code 800B, meaning that they're sort of a medium priority, and 800 is for people who appear to be in some sort of emotional distress. The average response time is very rapid because it's direct dispatch by 911, and it's on standby for response at 17 minutes. Client engagements, so those are the number of calls that the team receives. The number of engagements are lower, so there's definitely a fair number of calls where they respond and they're not able to locate the person for whom the call was initiated. But for those where they are able to engage the client, you can see that 61% of crises are resolved on scene and the client's able to remain safely in the community. And then 15% transported to hospital, 13% are linked to and transported to social or behavioral health settings, so non-hospital diversion. And then 5150s, so that's involuntary psychiatric holds in California, are only initiated 6% of the time. So that's a very low rate of involuntary holds that this team is placing, which I think is something that the team's very proud of. And there's additional information on a dedicated website, sf.gov/Street Crisis Response Team, if you want more information. On to the next slide, just a little more about the population that this team is serving. So we created a heat map by zip code, and you can see that in the center part of San Francisco, so some of the well-known neighborhoods in San Francisco, which include the Tenderloin Civic Center, the South of Market area, that's kind of the heart of San Francisco where people experiencing homelessness are most concentrated, and that's the population that this team is reaching. You can see for race ethnicity data, that the team is reaching about 16% Black or African American clients, 24% white or Caucasian, smaller numbers of Asian Pacific Islander and Hispanic Latinx. 48% we do not have good race ethnicity data on. You've heard me talk about this in other settings, that getting good race ethnicity data is so important. So I'm presenting it here as at least a partial snapshot. But you can see that there is, San Francisco only has 5% Black or African American population, and so you can see that the team very much is reaching more of that population by focusing on people who are experiencing homelessness, where there's an overrepresentation of Black and African American folks who are experiencing homelessness in San Francisco. And then client living situation, you can see 70% are experiencing homelessness and only 7% are housed or other. So, this team is committed to this population and very much reaching the population served. And so on to the next slide here, and then what I want to try to do is invoke the voices of people who are actually receiving these services in San Francisco. So we are fortunate to have received a research grant from the Robert Wood Johnson Foundation to conduct an in-depth evaluation of the implementation of the street crisis response team. And we're doing both a quantitative evaluation and also qualitative interviews with recipients of the service. And this is a quotation from one of these recipients that I'll read here. So they said, "I mean, you're usually out during the day and it's really uncomfortable. So you want to be high because it's miserable. And then you're going back to the shelter. It's not like, it's like not really somewhere to go. It's just somewhere to be out of the elements. Being in shelters is very difficult, and it wasn't easy. I ended up relapsing in there, and I was using drugs pretty much the duration of my stay there." So this is a common experience that we hear from folks in San Francisco who are experiencing homelessness. And this team was able to reach them. And I'll share another quote later about the impact that the team had on one of these service recipients. On to the next slide. And so what I want to do here is try to generalize a little bit. How do we tailor crisis services to really best serve people who are experiencing homelessness? And I'll go through each component of the continuum. So next slide, please. So for crisis call centers, there are many strategies. I've listed here just a few, and these are very pragmatic. I want to be very kind of specific and pragmatic. So this is an audience here of policymakers, of clinicians, of people who are impacting crisis services. And so as you're thinking, how is my program actually serving people who are experiencing homelessness? I want to really highlight here are some practical tips that could be helpful. So for example, developing dedicated protocols for third-party callers who observe concerning behavior in public spaces. That's where a lot of these calls come from, is a passerby or a bystander seeing somebody in public space who looks like they're having a hard time. Having dedicated protocols for handling those third-party callers or those bystanders is very important to know that we're handling them well, and including offering the caller options not to transfer their call to 911 if a police response is the only available resource in a catchment area. Partnering with local 911 and public safety answering points to identify common homelessness-related calls for diversion to non-police response. So this is, if you're able to have a pathway so that homeless-related calls that previously might have been handled by 911 but can actually be better addressed by a non-police response, that's an important piece to build in, because often there are specific homeless-related police codes in a public safety answering point system. Setting standards for how to collect location information from people who do not have an address and are calling for help. Sometimes it's hard to find folks who are experiencing homelessness, as I described. Even the street crisis response team that's dedicated to this can still have trouble tracking folks down who are appear to be in distress. And so having those best practices at least figured out ahead of time is a concrete way to support this work. And then also supporting callers, especially those third-party callers who may themselves be in distress. It can be very upsetting when you see somebody who's in public who looks like they're in some sort of crisis. As I think many crisis call centers have experience with, when you're getting those third-party calls, it's important to also sort of treat the caller as somebody themselves who might need support. Next slide. So for mobile crisis teams, one of the absolute strengths of our street crisis response team is that we include peer specialists with lived experience on our team. Often it's our peers who are the first people to make contact with somebody who's in crisis. And it's so important for that rapport building and really meeting somebody where they're at. Building in outreach and engagement activities during downtime. So mobile crisis teams, often they're extremely busy throughout the day, but there is also downtime. And one way for that downtime to be spent is to have outreach and engagement, especially focusing on people who are experiencing homelessness, as a really high yield use of that time to get to know community. I mentioned that the street crisis response team in San Francisco is neighborhood based. And that means that it is there are specific teams that work in specific neighborhoods every day. So there are 6 teams, now actually 7 teams throughout the city. And those 7 teams have catchment areas within the city where they're constantly embedded in those communities so that they can really get to know local folks. Having transport protocols that should include best practices for moving belongings and caring for pets. These are important issues for people who are experiencing homelessness. And then also offering non-emergency transport options to shelter and emergency housing. So having those relationships established. Next slide. For crisis receiving facilities, you often hear the idea of a no wrong door approach. So having a really low barrier model that allows for walk-ins, again, including peer specialists with lived experience as a core part of the team, creating a pull model by co-locating with drop-in social service resources as well as basic needs like food, water, showers, and laundry. Often crisis receiving facilities are a precious resource, but if you have a crisis receiving facility co-located with other types of resources that can pull people in, there's so much stigma about mental health. There's such a high bar just at baseline in the community for people who are experiencing homelessness to actually enter into any kind of services, given that often people have had really negative experiences, they've been put on involuntary holds, they've maybe experienced seclusion and restraints, they don't want to have anything to do with mental health systems. And so having services, thinking of that, Maslow hierarchy of need, food, water, showers, laundry, shelter, basics, these are the things that people are looking for who are in crisis. And so co-locating these types of services that can then benefit from the expertise of a specialty mental health crisis receiving facility can be really high yield. And then embedding housing access, either in person or remote, within receiving facilities that often serve people experiencing homelessness. Housing first is clearly a model that's widely disseminated across the country. Hard for somebody who's in sort of chronic crisis, repeat crisis, to exit that crisis without having greater stability in their housing situation. And so ensuring access to housing is really important. Next slide, please. And then finally, post-crisis follow-up. So I think of this as really a core component of the crisis continuum, and there's many opportunities for follow-up with these folks. So, partnering with outreach programs and mobile crisis teams to locate people who are otherwise not connected to services as a part of the crisis continuum. Supporting people who are experiencing homelessness with navigation services to help jump through complicated hoops in the system. It's so hard to navigate these systems, right? And so having navigation services, which could be peer navigators or other navigators, to really stand shoulder to shoulder with people who are experiencing homelessness and help them navigate these systems can be, again, really important to supporting them to getting to a better place. And then minimizing specific appointments and prioritizing drop-in hours. So the reason I say this is appointments they just don't work for people who are experiencing homelessness. It's so hard to get to a scheduled appointment time, either keeping track of the time and day, making it work to have their belongings secured and, in a way that they're going to be able to make it to a specific appointment at a given time. It's just really hard. And so having drop-in hours for any kind of follow-up resources where somebody can self-present is really important and can be very high yield and is much more person-centered. Next slide, please. So I'm going to pivot here to wrapping up. I wanted to share this second quote that I had mentioned. So again, a recipient of Street Crisis Response Team services here in San Francisco. It was the most important, most wonderful thing that I've seen. Way different than an ambulance, way different than the police. Police just stands there and tells you what's wrong. and they go through your background and they sit there and chat. They don't talk to you like the crisis team. They was telling me, how you doing? If you want some water, what are you hearing? What are your symptoms? And they were there. They didn't take that long like the ambulance did or the police did. So clearly, a very different experience of having this kind of team coming and serving somebody, given how many other experiences, obviously, they've had with both ambulances and police. Next slide. So key takeaways from this that I hope you come away with. So peers, 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 so important for all of these programs, as we talk about often here. Always remembering, Maslow's hierarchy of need, first things first, the basics, food, water, housing. Again, being aware stigma and bias at every turn in how we're both designing our systems and also serving people. Protecting people's physical, emotional, and material safety is really important given how vulnerable and exposed so many people experiencing homelessness are, and that every contact is an opportunity for engagement. So with that, I think the next slide is just a thank you, and really appreciate your time and interested to hear from the roundtable.
Matthew, thank you so much for your fabulous presentation. It was so informative. As I was listening to it, several questions came to mind. I would have questions about addressing the intersectionality of people not only experiencing homelessness, but all the other things going on with them at the time. I had questions about how you address the social drivers, and time again, you address those questions. So such a thorough presentation, such a thorough program. So this time we are going to pivot to our roundtable. So I will invite now Kevin Martone, Executive Director of TAC, Board President with NARMH, and Shelley Polanco, State Policy Manager for Vibrant, to join us for the roundtable to share any thoughts, any questions, any takeaways they have from the presentation.
Thanks, Vic. And Matt, thanks. I mean, Matt's always sort of concise and spot on with these conversations. And I just wanted to sort of reinforce a couple of things that he said from my perspective and experience at TAC and in my work in New Jersey. A couple of things at the clinical or sort of workforce or program level to sort of reinforce. And, a lot of the clinical interventions are, similar to what you would provide anybody who may be experiencing a behavioral health crisis, but to some degree, there's got to be some emphasis added. And what I mean by that is you have this intersection of when you look at things from a racial perspective and demographics, right? We can sometimes talk about how people who are Black and brown skin who are overrepresented in crisis systems, but they're also overrepresented in homelessness serving systems or people who are experiencing homelessness. And so you have to sort of even think more about that intersection there. When it comes to trauma, people who are homeless, and particularly women who are homeless, experience a disproportionate amount of trauma. The numbers, particularly for women, are staggering. And so we really have to augment trauma-informed care principles when we're working with people who are experiencing homelessness. And just to reinforce that point that Matt talked about in terms of personal belongings, right? So, if a person's living in an apartment and they experience crisis and maybe they're going to go to a crisis stabilization program or an emergency department, you can kind of close the door and lock the door to your apartment when you go out the door. But for people who are homeless, you can't minimize that they may have all of their entire belongings with them, including their pets, who may be their most important support systems. And we really need to think that through. Just a point on calls. I know in terms of 911 calls that I've looked at in different jurisdictions, the number of calls related to people who are homeless is significant. And that's not always just people who are experiencing a behavioral health crisis, like a mental health call or substance use disorder call. But a lot of times those calls come in for people who are homeless for, sleeping in a place that they shouldn't be, or those petty nuisance crimes. And it's really important for 911 calls and certainly 988 call centers as we go forward to try to differentiate what the essence of that call is, to try to identify the most appropriate response. That may not always be a behavioral health crisis response. We're always trying to, have less of a crisis or law enforcement response for sure, but it may be another social service that may be more appropriate to respond. It's hard to disentangle though when we know the correlation or the incidence of homelessness in people with behavioral health diagnoses, mental health, or substance use disorders. It's hard to disentangle that, but it's really something we have to do when you look at the overwhelming volume of calls that are coming in for people who are homelessness. And if you just look at Matt's data on San Francisco, the vast number of calls are for people who are homeless. And lastly, just getting into a couple of the systems level issues then, one key point for us to think about is, we talk about a behavioral health crisis in this country, but we also have a coexisting housing affordability crisis. That's not getting any better, even though we've had an influx of affordable housing resources out there. The cost of housing and vacancies in communities, particularly our large urban centers like San Francisco and the other big cities, is hard and maybe getting worse, and that will impact us. And just to drive home the importance of cross-system planning between behavioral health crisis services and homelessness services and systems. We need to be really, really intentional about the roles and accountability when it comes to responding to calls for people who are homeless. There's not necessarily a cookie cutter approach, a right way or a wrong way to do it, but we have to have that conversation. We can all agree that law enforcement should have less of a role, but who does what on a behavioral health and social services side may look different by system or community. Nevertheless, it really needs to intentionally be discussed. And finally, there, I think, needs to be a discussion even specifically on youth experiencing homelessness who may engage with law enforcement and have behavioral health needs, as well as in family homelessness situations. Is it a behavioral health issue? Is it a child welfare issue? Is it a housing issue? All of those things and those cross-system efforts really need to be intentionally discussed between these systems. I'll see if I can even put it into the chat, but we had done a report for NASHBID in the SAMHSA document, that crisis document that was issued last year, specifically on systems level issues for behavioral health and homelessness systems for cross-system planning coordination. So I'll put that in there, but I'll pause there. Thank you.
Yeah, thank you for that, Kevin, and thank you, Matthew, for your presentation. I just want to share a little bit of my experience. I worked for a New York City homeless shelter, a 200-bed shelter for men with substance abuse and mental health for about 3 years before coming on to Vibrant. And I just wanted to highlight some of the points that you mentioned and some of the hands-on experience that I've seen, especially in New York City, and people experiencing homelessness. One of the main concerns that I had was, being a Latina and seeing, Black and Brown populations kind of like being underserved in New York City, especially the Latino population. And I felt that they were very misrepresented in psychiatric care. So a lot of them, did not feel uncomfortable and felt further stigmatized receiving care and going to these centers and having psychiatric because of the stigma around mental health, especially in the Latino community, and also the lack of Spanish-speaking psychiatric cares. So having to use a language line and feeling very impersonal with their psychiatric help or care system. A lot of them felt like they weren't being understood or weren't having that personal experience that anybody like an English speaker patient would have. So that's one of the things that I definitely saw in my experience there. And I wanted to touch on, the no wrong doors and having that open door policy. Something that I noticed even as a caseworker is true. A lot of, patients, people experiencing homelessness are really bad with keeping appointments. And a lot of things, especially when you're in a crisis, you want to kind of have that service when you need it and not make an appointment and wait 3 weeks or wait 4 months for the next appointment, especially how we saw during COVID. A lot of the patients and a lot of the clients were very frustrated with having to wait such a long time or, telehealth through, screen. They felt very disconnected with the service that they were receiving. And we saw that a lot of clients were, not going to their appointments and kind of like missing out on a lot of opportunities to kind of receive that care. And another point that I really want to touch on is housing. One of the things that we saw a lot, especially for the clients, was that, they're in shelter, already traumatized, already stigmatized, already going through, whatever they're experiencing. And then once they receive housing, not receiving that same service anymore, of having a case manager there available, or having, you know, a medical center right across the street, kind of like that disconnect of being away from their service or their routine after moving out of the shelter system. We saw a lot of clients coming back within 6 months to a year because of the, you know, not continuing that care or not having those peers available or that case manager available there. And I also wanted to touch on, you know, clients going into the hospital. So once they're having a crisis in the shelter, a lot of the things that these, you know, shelter staff do, just call 911, call the ambulance, and they'll be transported to the hospital. What ends up happening is in the hour, 2 hours, they're back into the shelter and they're not receiving the actual care, the long-term care that they need. Even if the hospital kind of provides like a follow-up or gives them like paperwork, a lot of the clients will not follow up with these services, or, you know, the service is in another borough and they can't make it, or they can't go, can't keep up with the appointments. A lot of the clients don't have cell phones, or, you know, a lot of these things. So what happened during COVID was that, you know, these clients couldn't do a telehealth or FaceTime call with their doctors because they didn't have that availability. So I think that what we saw, especially during COVID, was that a lot of these clients and a lot of these patients kind of were very disproportionately not taken care of, or not being able to receive the care that they needed. And I think further stigmatizing, further kind of like made them marginalized in these areas. So I'll just finish off with that. I mean, I can go on, and there's so many like different things that we can add, you know, about substance abuse and, you know, everything. But I think this is definitely something that we need to kind of expand on, especially the lack of language, like different languages services for not just Spanish speaking, but other immigrant communities coming into the shelter system and not having access to services or, you know, that help. So thank you.
Thank you. Thank you, Kevin. Thank you, Shelley. And again, thank you, Dr. Goldman, for such a fabulous presentation. So at this point, just want to remind everyone about our jam session t-shirts. There are 5 available, 5 different quotes. I will tell you, I will have to have one of each. But I do encourage you to purchase these shirts. They are not only informative, they are clearly fashionable. And from what I understand, they are guaranteed to give you leaner, tighter abs. This leads us into our hot seat. And as a reminder to our hot seat participant today, who happens to be Kevin Huckshorn, Executive Vice President of the Northeast region of RI International, as a prize today for participating in our hot seat, you will receive one of these jam session t-shirts. Where other game shows may give you turtle wax or Danny Moore beef stew, we give you a fashionable jam session t-shirt. So Kevin, are you ready to participate in the hot seat?
I am, Mr. Armstrong.
Very good. And let me remind you, you do have the option to phone a friend if you need to. So welcome to the hot seat. And let me give you today's hot seat trivia question. And this is learning from 911. Dispatchers focus on assets to put into the field, and closest may not always be the best. They consider the complete capabilities of each resource. Central Square 911 software may include which of the following capabilities and or assets? Your options are A, Spanish speaking, B, dog catcher, C, CIT trained, or D, all of the above.
Okay, well, I would like to phone a friend. And my friend today is going to be one of the smartest people I know, Wayne Lindstrom, who I believe is on the line. And Wayne, I'm leaning toward D, but I would really like your thoughts.
Well, of all the questions that you could have chosen for me to be your assistant, this is probably so outside my wheelhouse to competently provide you with any coaching with regards to the response. But as I went through each of these, like you, I thought all of the above might very well be the answer. So I'm going to agree with you.
All right. And then we are going to agree with our very smart audience. So my answer is D.
D, is that your final answer?
That is my final answer.
All right, let us review. You are correct. The answer
Yay!
is all of the above. And you were right to go with Wayne and to go with our audience because, of course, we bring only the best and brightest to the Crisis Jam. So thank you so much for participating. We will make sure that you get a lovely t-shirt for your participation.
That is awesome. Thank you.
Thank you. This now moves us into crisis talk. And so at this time, we will turn it over to the lovely and talented Miss Stephanie Hepburn.
Thanks, Vic. So I'd like to welcome Dr. Ron Mandersheed, Scheid, actually. He's the Executive Director at the National Association for Rural Mental Health. Ron, you shared that in rural and remote communities, there's an increased need both for telemedicine to overcome barriers, but there's the contradiction, which is the internet and phone access can be far from reliable. Can you talk a little bit about the impacts of the digital divide?
So thank you for inviting me. And just a slight correction, I'm
Oh,
the
okay.
former executive director of the National Association for Rural Mental Health. Lovely role, but not currently the executive director. So first on the digital divide, I guess I'm kind of shocked that I'm sitting here in 2022 continuing to talk about this problem that we have been talking about for 10 years. This is not a new problem, basically. And what is it? It's really a community divide. Certain communities have wonderful technology. Other communities have next to nothing. Communities that have next to nothing, the children in those communities literally don't have the internet to do their school homework. And they don't have a reliable internet to do their school homework. Our providers in the rural communities can't use tools that everybody else takes for granted. Emails and websites and all these apps on websites to deliver services. So it remains a very serious problem, not one that is not receiving attention. It has been receiving attention in a number of places. It received attention in the American Rescue Plan. It received additional attention and is likely to receive more attention in the Biden Behavioral Health Plan and so on. But we have to keep pushing on this. It's not literally solved at this time.
So you talked about that, but you also talked about building self-empowered communities. Can you talk a little bit about what does that mean?
So there's a huge amount of very important work going on right now to build self-empowered communities as really the third dimension of the work that I think most people who are on this call do in behavioral health. So the initial level was to look at behavioral health problems, then we added health problems. Now we're adding community as the third dimension of that work because of the absolute critical importance of the social and physical determinants of health. And so I've been very excited about some of the work that's going on in the US and other countries to actually begin building empowered communities. I want to specifically cite the work of the Hogg Foundation in Texas as a very good example of this. You can go to their website and read more about this. So going into a community and saying, what do we need to do? We need to listen to the community. We need to include historically excluded groups. Every community has historically excluded groups. And in the Texas cases, it's most likely to be Hispanics or Blacks, but it could be anything. In a school classroom, there is a historically excluded group in that classroom. We need to understand what that group is and do something about it. We need to recognize there are emergent leaders in that group and to foster that emergent leadership and let it come forth and let it operate. And finally, as we do these things, we need to actually celebrate good things that happen as the community becomes empowered and comes together. We need to have social events, dinners, dances that people come, bring their children and so on, and interact with people they've never interacted with before. Huge opportunity here. So those are kind of the principles that are emerging in this work. Hogg Foundation is working with 7 counties in Texas to do this. Other countries, Canada is doing this in 2 of its provinces. Australia is doing this in one province, New Zealand is doing this, and Netherlands are doing this. And the underlying principles are always the same. If you do these things, then very interesting things begin to emerge. You begin to see outreach to people who have problems in the community, the people who are socially isolated in the community. You begin to see the development of chat lines. You begin to see the development of drop-in centers, all these types of things that begin to move us upstream from stage 4 care that we've done in behavioral health for decades into, I'm going to call it, very primitive efforts at prevention. Empowered communities can be a very important tool at prevention and promotion. So if you don't know much about this work, it's new work. I encourage you to go online, read more about it. It's very exciting, actually.
Thank you, Ron. I think the other thing I'd like to point to really quickly is you talked about how essential it is for primary care in rural and remote communities, those primary care physicians to have sufficient training to be able to connect people to resources and not, like you said, just prescribe medication without fully understanding the mental health nuances.
So just a few words about that.
Yeah.
Very important workforce that's available to us are all the primary care physicians in the US, including those in rural areas. What we know about those primary care physicians in rural areas is they tend to be older. They tend to be also tend to not have very much formal training in behavioral health. A lot of those people didn't have more than 3 or 4 hours of formal training in behavioral health as they went through their training. So then if you look at them, 25, 30 years after their training is over and say, well, how much do these people know about modern medications? How much do they know about modern interventions we're doing? How much do they know about recovery? I think, we find them very, very wanting, not because they aren't well-intentioned, but because they don't have the current training they need to have to actually participate effectively. So we have actually advocated with FDA and others that you need to institute training for these rural primary care physicians. And, what are the modern meds? When are they indicated? When are they not indicated? You don't just do this by trial and error, which is pretty much how the system has operated and so on. When we need to extend the opportunities to them to participate in short-term training, we need to have IT tools available to them. So when they come to a difficult case, they can do some personal research on the case, or they can contact a person in the ECHO group, for example, at the University of New Mexico, et cetera. There are a number of things that I think we should be doing with our rural primary care physicians, because they're really the first line we have of care in many of these communities. You all know as well as I that 85% of the counties in the United States have either no behavioral health services or inadequate behavioral health services. And many of those places, the only line of defense is the rural primary care physician.
Well, Ron, thank you so much for hopping on the call. I'm going to pass it back to you, Vic.
Thank you, Stephanie, and thank you, Ron. One of the things that just jumps out to me from the conversation is as a chief diversity officer with RI and a former chief health equity officer for the state of North Carolina, one of the things that I've seen all too clearly is that when we talk about equity, and particularly when we talk about health equity, and historically marginalized populations, that we often don't think of people in rural communities as being historically marginalized, but in many ways, in accessing care and accessing services, they definitely are. So thank you for that. So at this time, we will pivot to our updates, beginning with our SAMHSA update. I believe we're going to hear from John Palmieri.
Thanks, Vic. I'm actually going to turn it over for a couple of quick updates. The first from our digital communications lead, Stacy Pulaski.
Hi, everyone. It's good to see you all again. So I know a lot of you are already using our partner toolkit on the samhsa.gov/988 site. Thank you all. And I loved seeing the logo on the t-shirts, Vic. We have an update this week, which is many of you have been waiting very patiently for print materials, wallet cards, magnets, posters, that kind of thing. We posted all of the print materials into the toolkit yesterday. And the first of the materials is available in the SAMHSA store for ordering. So they are going to be starting to arrive. It's they're coming over the next couple months. So apologies for things that take a little longer than we would like. That is a result of the supply chain that is going on in our country. But in the meantime, what we've done is made sure that every material that we've created that is going to be showing up in the store, in the SAMHSA store over time, is all of those materials are available online for all of our partners to go ahead and take, download. We've put out just regular print files that you can print on a printer, as well as the particular printer friendly with the print specs on them if you want to print large scale orders for everything. And I'll stop there for questions.
Thanks, Stacey. And yeah, if there are questions, please feel free to put them in the chat. And then I think we're going to pass it over to Richard McKeon for a quick update.
Thank you, John. So I wanted to mention that last week we did have our SAMHSA Policy Academy on 988-911 coordination. That was in for 5 states: Maine, Georgia, Minnesota, Colorado, and California. I thought it went very well, and the feedback that we received and the information that was exchanged was of significant value, and will really play a key role as we do a deeper dive into this vitally important area. Other pieces of this, of course, have been the playbooks for 911 public safety answering points and lifeline crisis centers. Vibrant hosted a meeting of subject matter experts looking at the content of when a suicide-related call should go to 988 versus 911. And Vibrant will be starting a community practice and learning collaborative in the upcoming months. So again, this is something that we think is an extraordinarily important area. And as one state official stated that, 988 and 911 will be inextricably interwoven in the public's mind. So are working together both to be able to divert from unnecessary 911 calls, which has the potential to reduce unnecessary police involvement, but also to be able to quickly access 911 services for which 911 is the gateway, such as emergency medical services. When we learn on the lifeline about a suicide attempt in progress, something that occurs each and every day. These are all vitally important issues for the success of 988. And certainly people can feel welcome to contact us or contact me if there's work that you're doing in this area that you want us to be aware of, because we continue to find some excellent local examples that have been operating under the radar. So thank you very much.
Thanks, Richard. Back to you, Vic.
Thank you to our friends at SAMHSA. And at this time, we will turn it over to Brian Hepburn for our NASPID update.
Thank you. I'll try to be very quick. Thank you to Richard, John, and the SAMHSA team. They continue to provide great leadership. Thank you, Vic, for your leadership today and also for your ongoing advocacy. It's great to see you on social media. We really appreciate all your efforts. Also, thank you to Matt Goldman and his emphasis on people who are experiencing homelessness. Megan put a couple of papers into the chat that we have worked on at NASPID on homelessness. One of the papers was brought up by Kevin Martone. I want to thank Kevin and Shelley for their participation as well in the roundtable. States are continuing to deal with 988 readiness. They're anticipating, they're ready, they're anxious, but looking forward to getting started with the 988 kickoff. and continuing to work on the issues of workforce. And of course, as you all know, the issue of mental health issues in schools and how do we bring safety to schools. So with that, let me give it back to Vic. Thank you.
Thank you, Brian. And we will now pivot to Sarah Corcoran for our federal updates.
Thank you, Vic. So I'll be quick as well. The House Energy and Commerce SAMHSA and HRSA reauthorization bill that we've been talking about did pass out of the House last week. So far, we are waiting to see how the Senate counterpart coming out of the Senate Health Committee will come together and shape up later in the summer. The other update I wanted to give was a quick appropriations update. Last week, the House Labor HHS subcommittee released their bill text for the FY23 appropriations bill, including a summary. And earlier this morning, they did also release the committee report language, which gives us more detail about their funding allocations. It looks like SAMHSA has been funded with an increase of $2.6 billion above the last year level for this House version of the bill. I will drop some links to the summaries of the different breakdowns in this House bill, but just something to keep in mind that the overall amounts will likely be lower than what is in this House bill, because they will have to come to agreement with the Senate side on final numbers, but still an impressive bill and showing for mental health funding and priorities coming out of the House. And we will hopefully have more updates later this summer and into the fall on how the Senate bill shapes up. And I will pass it to Joanna from AFSP.
Hi, yeah, so we also have a quick update. As we mentioned last week, Congress took very swift action on the first gun violence package we've seen in 30 years. So that was really exciting. It involves a lot of mental health supports as well, which is really great to see. It's the Bipartisan Safer Communities Act, and it was signed into law on Saturday. Most notably, I'll just run through a few quick things. I know we're running out of time, but most notably, this includes the $150 million for Lifeline operations, and that comes in addition to the levels that were provided in the FY22 budget. So that's really exciting to see those investments. We also have some school-based mental health services grants and mental health services professional demonstration grants, each funded at $500 million over FY22 through FY26. So that's really good to hear. And there was also funding to implement extreme risk protection orders and tighten some loopholes that allow young people to access firearms and to limit access to firearms for people who have been convicted of domestic violence as part of a dating relationship. That's the boyfriend loophole. So really great to see, exciting that the president signed it so quickly, and we're really grateful for those investments. And I'll pass it back to Vic.
Thank you so much. And do we have state updates? I believe Pastor Nick is going to speak to that.
Yeah, Vic, thanks. So for this update, I would focus on California and New Jersey. So just a reminder that California has some pending 988 legislation known as AB 988. The amended version of that recently passed out of the Governmental Organization Committee and is also being heard this week in Senate Health. Also on California, the California legislature recently agreed to its budget. It's just some high-level funding highlights for 988 that I'll mention. There's $8 million for in one-time funding for 988 call centers. The state is also taking up the enhanced Medicaid matching rate for mobile crisis teams, so there's some funding for that. There's also one-time and also ongoing funding to support 911 and 988 interoperability, and also $1.5 million to support planning for behavioral health crisis continuum of care. And I'll actually turn things over to Shelly Polanco at Vibrant to cover New Jersey.
Thank you, Steph. So really quickly, Senate passed S311 ambiguously earlier this month on June 16th, and the Assembly will vote on the counterpart, so A2036 tomorrow, I guess today. Although the bill does not include funding, the funding for 988 is included in the recently released budget bill, so for $12.8 million for the 988 hotline, and the amount is recommended by the Governor Murphy, and $16 million to create mobile crisis teams.
Thank you so much. And here we have our state cards. We have 4, I believe, that we have listed here, but as a reminder, you can find the state cards at our learning community site at talk.crisisnow.com. And as a reminder too, that the Washington State card that was just on the screen there, next week we will have Tina Orwell, who will be here to talk to us about Washington State. For our tools, I don't believe that either Tom Betlock or Paul Galdis are here with us today, but as a reminder, our Crisis Now calculator is always available to you as well. Next slide. Also want to remind everyone about Moving America's Soul on Suicide, that there are 5 episodes now that have been released to this point, more to come for a total of 8 episodes. So we definitely encourage you to tune into that. Next slide. And then coming soon, as I mentioned, we'll have Representative Tina Orwell talking on 988 from Washington State on July 6th. And then on July 13th, we have Dr. Miriam Delphin-Redmond from SAMHSA talking about our 988 Goes Live. So thank you all so much for being with us on the Crisis Jam today. We invite you to come back and join us every Wednesday at noon Eastern Time, 9 Pacific, where as always, we be jamming. Thank you.